Hello, everyone, and welcome to this edition of the ESID Grand Rounds webinar on updates on registries and collaborative studies in COVID and PIDs. I'm Fabio Candotti from the University Hospital of Lausanne, and together with Isabelle Meyts from Leuven in Belgium, we will try to moderate this session. We are lucky to have three experts panelists today. We will have Nizar Mahlaoui, Adrian Shields, and Stuart Tangye that will present their experience on the topic.
Thank you very much, Fabio, and welcome to you all. Thanks for tuning in. And I want to wholeheartedly welcome Nizar Mahlaoui, who will give us the first lecture on the data that he has gathered with the COVID study. Actually, since March 2020, and so we are looking forward to hearing about his data. Thank you, Nizar.
Thank you very much, Isabelle and Fabio. Thank you to ESID for giving me this opportunity to share with you the first update, the first publication really, or sharing of information from the COVID registry. That is a worldwide registry of COVID-19 in primary immunodeficiencies that really started, as Isabelle said, a few months ago at the beginning of the pandemic. As you can see, it started in late December 2019 and spread obviously all over the world. And at that time, we were all in the PID community and all stakeholders very worried about the impact of this pandemic on patients with primary immune deficiency. So that's why we started this collaborative effort of COVID-19 in PID patients, and we were already aware of the fact that it could affect all age groups, both genders, and with the specifics of some comorbidities as a background, with age being one of the major factors, being a male, having an obesity, heart condition, diabetes, kidney disease, lung disease, and immune abnormalities. And since the beginning of the pandemic, more than 150,000 papers are indexed in PubMed. So it's been a huge effort. And as of yesterday, this is the dashboard of the number of cases and fatality cases. So almost 5 million deaths out of 244 million cases in all continents. So we all together as a worldwide community came together with a statements that were updated subsequently and firstly published at mid-February of 2020. And it led to the first effort led by Isabelle Meyts on the gathering of information on COVID-19 in patients with inborn error of immunity, and the first report of an international study that you were all aware of. And it was really the first step to build on with this registry, the worldwide registry called COVID-19, and this is the continuity of this first work. So far we collected 165 patients all over the world, and you can see the countries in Europe, in Latin America, in Asia, and also in the US and Mexico and Canada. So thank you to all the colleagues, and they will be mentioned at the end of the talk, for registering patients in this database. So main PID categories were as follow: mostly predominantly antibody deficiency, so 2/3, 1/3 with combined immune deficiency, and a few other patients with diseases of immune dysregulation, defects of phagocyte number or function, and a few others. A more detailed in breakdown of this, as you can see, mostly patients with CVID, and a few patients with a documented genetic defect, an FKPD1 or 2, and a PDS, A gamma, mostly Bruton disease, and other antibody deficiency. And in the combined immune deficiencies category, there were patients with hyper IgM, DOC8, ATM, STAT3 loss of function, and a few others as well, and a few patients with SCID as well. So interestingly, and among the diseases of immune dysregulation, mostly patients with LPS, FHLH, and IPEX or IPEX-like phenotype, a few patients with CGD, and STAT1 gain of function, and a few patients with autoinflammatory disorders. So 60% of these patients had underlying conditions, mostly bronchiectasis, asthma, diabetes, hematological malignancy. A few patients, only 3, underwent a bone marrow transplantation in the less than 1 year ago. A significant amount of patients had an inflammatory bowel disease, 12 of them, chronic liver disease, 8, chronic kidney disease, and heart disease for 9, and mental illness, which was quite surprising for 10 of them. Patients were under chronic anti-infectious prophylaxis for 73% of them under IG replacement therapy, 1/3 under chronic antibiotic prophylaxis, 10% and 6% under antifungal or antiviral prophylaxis. Sorry for a duplicate here. 31 patients, so a minority of them, were under other drugs affecting the immune system, and mostly azathioprine, corticosteroids, and hydroxychloroquine, and high-dose IVIG. And a few other patients were under inhaled corticosteroid, cyclosporin, methotrexate, sirolimus, MMF, tacrolimus, 5-ASA for IBD, ibrutinib, anti-TNF, tocilizumab, and rituximab. So the demographics here is we have really a 1:1 gender ratio. The age of COVID-19 was 32 years old for a median age, ranging from 0.2 year to 83 for the oldest. The weight was the median weight was 60 kilograms, ranging from 6 kilograms to 140. The respiratory rate was quite normal for many of them, and one patient had a high respiratory rate of 117. The Glasgow score was for most of the patients normal. A few patients had a Glasgow score of less than 10, and one had a severe coma for admission. The reason for testing was that patient had a suspicion of COVID-19 with symptoms for most of them. Some patients were tested because they were contact of a case. A very few patients were detected at the entry of the hospitalization for some reason, and regular routine respiratory disease surveillance, for example, what we perform for influenza, was the reason for testing for COVID-19. So interestingly, the majority of the patients didn't need to be admitted to the hospital, for 54% of them. And the other patients were mostly hospitalized in a non-ICU setting for 30% of them, and 8.3% needed to be 14% needed to be hospitalized in ICU, and 8.3 needed to get an invasive ventilation, and 1 even needed to be put under ECMO. Clinical symptoms absent in 1/3 of the patient, which is very interesting, and I think kind of what we know in our experience, but it's nice to have it collected here. For the patient who had a clinical presentation, it was 60% of them had fever, cough, upper respiratory symptoms. 1/3 had dyspnea, 1/5 had chest pain. Interestingly, 28% had digestive symptoms, and 35 had myalgia, which could be assimilated to a flu-like syndrome, and 8% had a severe respiratory distress syndrome, and there were a few non-respiratory symptoms such as collapse, shock, 3%, and skin features with 4% with a cutaneous rash, 1% vasculitis like erythema, and we all know about the PIMS, the Kawasaki-like phenotype in 3% of the patients, and of note, 4% had neurological symptoms at admission. Other signs were the very well-known anosmia in 6 patients, dysgeusia, so alteration of the tasting in 4 of them. Interestingly, several patients had fatigue and severe headaches, nausea, and a few other symptoms here, as you can see. Co-infections were only found in 23 patients, and most of them were bacterial co-infection with Acinetobacter baumannii, Campylobacter, Escherichia coli, Enterococcus, Klebsiella pneumoniae, and multibacterial infection of different strains. 2 patients were found to have aspergillosis, and 1 patient was found to have a cytomegalovirus co-infection. And out of 11 patients tested, no patient had a flu detected. What about the chest X-ray and CT scan? They were performed for 35 and 29 patients respectively. And they were found abnormal in the majority of patients, so 67% for the chest X-ray, and bilateral features for the vast majority, mostly alveolar condensation. And there were also other signs of bronchial disease, pleural effusion, and cardiomegaly. And on the CT scan, we found even a higher percentage of bilateral involvement, and a few other extra pulmonary involvement that I don't have time to go into detail here. What about treatments received? Antiviral for 16 of them, remdesivir in 2, lopinavir in 1, flu therapies in 5, and antiretroviral in 4 patients. Hydroxychloroquine in 11 of the 17 patients for which we had information. Most patients received systemic corticosteroids and IVIG. A few other patients received heparin. As we know, it's also a thrombotic-prone disease. Anti-TNF for 1 patient, sorry for the missing information here, tocilizumab in 1, and MABs in 4 patients, and convalescent plasma in 9. So the outcome was pretty good 77% of the patients were alive and well at the time of documentation in COVID-19 survey. 14% of patients were still experiencing ongoing symptoms or had sequelae or still complications or comorbidities related to their COVID-19 infection, and 9% of the patients died subsequently. So as a summary and perspectives, this survey gathered information at a worldwide level of 165 patients. We still have more patients to document, but as we can draw a few messages here of 60% of these patients having underlying conditions that are more or less linked to an adverse course of COVID-19. But interestingly, 1/3 of the patients didn't have any clinical symptoms at the time they were tested, and 54% didn't need any hospital admission. 8% of the patients needed an ICU admission for invasive treatments, and we remember that 6% of them, 6% of the patients did need to go to ICU, but without invasive treatments, and the death rate in this population was 9%. So obviously, we need data for more patients, and I know that we can probably gather information on more patients as time goes by, but we also need follow-up documentations for the already registered patients in order to assess long-term outcome and sequelae. We also need to collect information on this phenotype of relapsing COVID-19, for example, in patients with Bruton disease and probably other PIDs. We also need to draw information on long COVID. Is it something that could be more prevalent in patients with inborn error of immunity? And we need to go into more details in terms of the effects of therapies if we can draw more information on that. So I will end here by acknowledging the huge contributions of many physicians around the world who contributed to the COVID-19, and they are not mentioned. All are not mentioned here, but the ones who contributed most are mentioned here. The team in Imagine Institute at the Necker Hospital who built the database, and the patients and families. Thank you.
Thank you very much, Nizar. That was very informative. For the audience, I forgot to say earlier that we're going to take the questions and answer the questions at the end of the 3 presentations. So please continue to put in your questions in the chat, and we'll get to it later. Now, our second speaker is Adrian Shields from the Institute of Immunology and Immunotherapy of the University of Birmingham. And Adrian has agreed to share with us the experience of the UK experience with COVID and primary immunodeficiencies. Adrian, please.
Thank you very much. Let me share this. Is that appearing clearly? So thank you very much for the invitation to speak and show some of the data from the UK. To put our experience in the UK in context.
Sorry, Adrian, can I just put in? Do you want to switch your swap displays? Because it's showing a presenter view, not as full screen view.
There we go.
Sorry.
Is that better?
Yeah, but yeah, thank you.
Brilliant. So this is the graph of cases in the UK. We've had we're now into our 4th wave, I suppose, of cases, approaching 50,000 now. And this is a map of the deaths that have been occurred in the UK. They've mainly come in 2 waves, with a prolonged wave over last winter, and we're ticking along at about 120 deaths a day at the moment. And that's sort of a significant outlier when you look at some of the other European countries, or certainly Western European countries. When the pandemic first arose, obviously as a community, as Nizar has also said, we were concerned about the risk to patients with primary and secondary immune deficiency who we look after in our clinics. And to try and address that question in collaboration with the UK Primary Immune Deficiency Network, we just started collecting data on physician-reported outcomes in the patients that they knew in clinic. So this data collection started in March 2020, and we were interested in two things to start off with: really, what the outcome was for our patients, and secondly, what was the impact of comorbidities, age, sex, and some of the other known risk factors that had emerged from other national studies. As we evolved through the pandemic and treatments became available that were targeted towards COVID-19, we also began to document the outcomes in relation to treatments that patients had had. This is entirely pragmatic. We can't gather information entirely comprehensively, just for practical reasons where patients are admitted to different hospitals, perhaps not their base hospital. But the only criteria to register and record data was either a positive PCR test regardless of symptoms or a clinical diagnosis of COVID-19. So we got data from a total of 27 of the 38 recognised immunology centres where patients are cared for in the UK. And by July 2021, we had 326 cases documented. And all of these patients were under the regular care of an immunologist. And we broke that data down three ways. Firstly, to generate a case fatality ratio. That's the number of patients who have a positive PCR who end up dying. Then the infection fatality ratio, those are the number of people who we think had COVID-19 who ended up dying, and then the inpatient mortality. And why present the data like this? Well, it's pragmatic, mainly because of the discordance between the number of cases and number of deaths early on in the pandemic. Across most nations, there was a lack of availability for testing. Certainly PCR-based testing in the UK was restricted to the hospital settings during the first wave. So at a time when there was significant COVID and COVID-19 in the community, we have made the assumption in a small minority of cases that these individuals had COVID-19. It works out about 10%. It also allows us to make direct comparison with UK public health statistics. Now, all of the statistics for testing and deaths are recorded centrally in the UK and not extrapolated from enhanced surveillance of any specific group. So we've got a really good comparison with the general population. With all those cases, we've broken them down into three groups. Firstly, common variable immune deficiency. Secondly, those individuals with a primary immune deficiency on immunoglobulin replacement. And thirdly, those individuals with secondary immune deficiency. And a preprint of these data are available now if you care to look at any specific PID in detail. So as a summary of the major groups here, we've got 93 individuals with common variable immune deficiency of median age 49 years. That's slightly older than the cohort Nizar presented previously. Similar hospitalization rates of 44%, but a higher case fatality and infection fatality rate. We've got a cohort of 26 individuals with X-linked agammaglobulinemia who are on average younger and have lower case fatality rates, and secondary immune deficiencies are on average a little bit older and have higher case fatality rates. So to look at our cohort of CVID patients, this is their age stratified mortality. So we've got cases across the full range above 20 years of age, across full range of age deciles. And across all of those age ranges, we've seen individuals who've passed away from COVID-19, but the risk really amplifies above the age of 50. We've looked at some risk factors for mortality in these patients, and age emerges as a significant risk factor, as one might expect. That's one of the most significant risk factors in the general population. But also a low pre-COVID-19 lymphocyte count is also a significant risk factor as well. Compared to the general population, individuals with CVID die on average about 20 years younger than those in the general population. And looking at a univariate analysis, we found other risk factors, including receipt of antibiotic prophylaxis, chronic lung disease, cardiovascular disease, diabetes, and chronic gastrointestinal diseases, all as individual risk factors for mortality in this group. Feeding those variables into multiple logistic regression, two things emerged. Firstly, a low baseline lymphocyte count, and secondly, those individuals with receiving prophylactic antibiotics are at high risk, and those are independent of one another. And we think that the antibiotic prophylaxis group is just identifying a group of individuals who are generally more comorbid. Looking at a slightly different cohort, those individuals with primary immune deficiency on immunoglobulin replacement, so casting the net a little bit wider than just CVID. Again, in terms of age stratified mortality, we see significant increases in risk above the age of 50. We see a similar pattern of individuals with respect to age and lymphopenia prior to catching SARS CoV-2, both significant risk factors. And then in comparison to the general population, we find that these individuals have a median age of death of 57 years. There's also similar risk factors in terms of their comorbidities. The same risk factors are emerging in the general population as well. So chronic lung disease, cardiovascular disease, chronic liver disease, and diabetes. So those two cohorts, or two ways of analysing the data, marry up well with one another. We've looked at treatments as well. We've restricted this piece of analysis to those treatments that have been shown to work in randomized controlled trials, particularly the recovery trials. And what we found is that the overall inpatient access to these treatments was actually pretty poor. Only just over 20% of individuals got a specific targeted treatment for COVID-19. That was mainly because they weren't made available until they'd been proven to work in randomized controlled trials. The overall inpatient survival in the cohort was just over 60%, and we found that there were some trends towards patients with primary and secondary immune deficiency doing better when they were given either dexamethasone, remdesivir, or an antibody-based therapy. Of the 5 patients who received tocilizumab, only 1 survived, and that may be because tocilizumab was being used and continues to be used in these patients as a drug of last resort, following dexamethasone rather than up front. But that certainly is something worthy of consideration and further discussion. So in conclusion, we found that individuals with primary immune deficiency are at high risk of morbidity and mortality from COVID-19. The risk increases markedly above the age of 50, and patients are dying at a younger age compared to the general population. Comorbidities, lymphopenia, and increasing age are all important, and lymphopenia is a particularly strong and independent risk factor that we've identified not only in CVID, but also PID with antibody deficiency, and it also emerges in our secondary immune deficiency cohort. And one standout message from this data collection is that we do need trials to understand the effect of the acute COVID-19 treatments in immunologically vulnerable patients, and avoid generalizing from the larger studies in the general population. With that, I'd like to thank the core study team, Professor Alex Richter, Sinisha Savage, and Siobhan Burns, and also all of our collaborators across the UK. Thank you very much.
Thank you very much, Adrian, for that overview. we'll discuss later on in the general Q&A session. And now it's my pleasure to introduce Stuart Tangye, professor at the Garvan Institute in Sydney, who's actually spending his night with us. And he will give us an overview of actually all the cases with primary immunodeficiency infected with SARS CoV-2 and all the studies that have been published since the beginning of the pandemic. Thank you, Stu.
Thank you very much, Isabelle. Thanks to Fabio and ESID. And are you seeing the big screen or the presenter screen? I cannot work this out.
We see a black screen.
No screen. You don't see
Nothing.
anything. What about now? No?
No.
Oh, okay. Hang on. Let me try something else. That was unexpected.
I can see it.
No, it's okay. Yeah.
Ah, Isabelle, you're tricking me. Okay, let's try that again. Oh, dear me. Sorry, I'll just try this. Oh. Okay, I'll try that again. Here we go. Hopefully. Okay, thanks everyone. Thanks, Isabelle, thanks Fabio, and thanks to Nizar and Adrian for that intro. I will skip over some of the slides that I have, which are a little bit redundant in the light of the presentations already. As Isabelle said, I'm going to try to summarize many reports that have described the impact of SARS-CoV-2, COVID-19 on patients with primary immunodeficiencies or inborn errors. And this is really synthesized from the literature, plus building on the publication that Nizar showed in his talk that was done with Isabelle and many other people across the world. So as you all know, particularly from I think Nizar's talk, this is what COVID-19 looks like at the moment. There's been nearly 250 million cases, nearly 5 million deaths. So the case fatality rate is about 2%. It does vary from country to country. I'm coming to you from Australia, so we have a CFR of about 2.5%. It's higher and lower depending on where you are, but in general, it's about 2%. And as we also know, as the pandemic kicked off beginning of last year, that obvious risk factors that became obvious very quickly were age and comorbidities. And these are just really nicely demonstrating that it didn't really matter what age bracket you were in. The likelihood of you being infected by SARS-CoV-2 was not that different from whether if you were relatively young, in your teens, in your 30s, 40s, and so on. The likelihood of being infected was pretty similar. And likewise, if you did or did not have a comorbidity, it didn't actually favor or prevent you from actually getting infected with SARS-CoV-2. But obviously, what was different in terms of age and comorbidities was death. As we know, deaths greatly increased in the older population as well as in those who had pre-existing comorbidities. But clearly the question is, what about people with pre-existing inborn errors of immunity or primary immunodeficiencies? So I was lucky enough to be part of this study, which, as Nizar mentioned, was led by Isabelle, but also involved Nizar, as well as many people across Europe and across other parts of the world. And this was one of the first surveys of what the impact of SARS-CoV-2 was having on primary immunodeficiencies. And these were the countries from which we had clinical information from patients. As you can see, across parts of North America, South America, and Europe, the UK, none from this part of the world. But all up, we had 94 patients and there were 9 deaths. So the case fatality rate was about 9.5%, very similar to what we heard in the previous talks to some extent. Since then, or at the same time, we've had many reports along these lines, which have come from various countries. So again, South America, European countries, the UK, the Middle East, but also in big cities like New York City, for example. And these have reported the outcomes from these sort of cohorts that have been aggregated from those areas, whether they be by country or city. And interestingly, as Adrian just alluded to from the work done in the UK, case fatality rate range from 0. So, for example, in this study in Israel, there was no deaths. In the study of hereditary angioedema from Brazil, again, there were no deaths. But then in some reports, particularly from Iran, the study from Iran, and again, the UK study, the case fatality rate was quite high, up to 40%. So I've, together with Isabelle and Georgia Buckel, working with Isabelle, we've really looked through the literature, and we found about 650 or so cases that have been reported of patients with primary immunodeficiencies and infected with SARS-CoV-2. And again, as we've heard already, about 30% of these individuals were asymptomatic or had mild disease. This number varies on the definition of asymptomatic and mild disease, obviously. And again, demographics, the age of the immunodeficient patients was generally lower than what was seen in the general population. So 24 versus 48 years in the general population. But this varied with the type of immunodeficiency that was being looked at. So, for example, looking at all of the patients, as you can see here, this is all, 500 or so patients of which the age information was available. The mean age is around 24. But then for some other defined conditions, such as XLA, CGD, familial Mediterranean fever, and so on, the age varied. And then CVID, it was a little bit higher. But in general, it was younger than the general population. There was no correlation between the type of primary immunodeficiency and disease severity. However, there was a greater proportion of young patients who required hospitalization and ICU, including mechanical ventilation. And again, this is a table from a review that was published very recently, and it includes a lot of the patients that I'm talking about. There's 600 plus reported here, broken down by type of immunodeficiency. Again, very similar to what Nizar outlined for the COVID study. But you can see the ICU admission rate, again, varied from 0 to quite high in the 60%, 70%. But it's generally higher than what we see in the otherwise healthy population. And again, the case fatality rate ranged from 0 up to 50+%, depending on the type of immunodeficiency in that context. So quite a bit of variability, but in general, there was no correlation between the type of disease and severity of COVID-19. In terms of fatalities, 49 deaths, so case fatality rates about 7.4%. This is obviously compared to what I said at the beginning, which is 2.1 globally. So that sounds much higher and looks much higher, but I think it's important to recognize that these days the global case fatality rate is much lower than what it was 12, 15, 16 months ago, when it was as high as 15, 20% in some parts of Europe, some cities in the US and some parts of the UK. I mean, clearly there's very high level of surveillance testing at the moment in the general population. We're certainly not seeing that in the PID community. So this is probably an overestimate of the number of patients who have been infected, given that a very large proportion of PID patients were asymptomatic. But almost all had pre-existing comorbidities, again, as mentioned previously: infection, cancer, obesity, hypertension, or post-stem cell transplant. But there's a few interesting observations, break it down by disease. So again, like for CVID, we found about 220 cases, 15 deaths, so case fatality rate 7%. And as you can see here, the average age is about 40, but the age of death is higher, about 60. And that's sort of shown here. So case fatality rate's around 7%, and it fluctuates either side of this average for the different types of inborn errors of immunity. B-cell deficiency, agammaglobulinemia, whether X-linked or recessive, very similar to the overall average. But in this case, the 4 individuals who died at average age was less than the average age of the 50 plus A-gamma patients. And many of these patients were successfully treated with convalescent plasma. And what's interesting, there's some inborn errors such as complement deficiency or complement defects, as well as ataxia, telangiectasia. Now there's been a number of cases reported, but no deaths, and that's shown here. So the case fatality rate for those inborn errors is actually 0, which is quite fascinating in itself. So this is coming back to a point I made a minute ago about comparing case fatality rates in inborn errors versus the globe. And this is a really nice study from Italy, led by Isabelle Quinti and the Italian team, which actually, due to surveillance testing in Italy, they could actually come up with comparative incidence per 100,000 as well as comparative infection and fatality rates for the general Italian population, shown down the bottom here. So that's about 3% infection and fatality rate across all of the Italian population, which differed depending on age category, above or less than 18 years of age. And again, when you look in the inborn error categories, pretty similar to the general population. So I think this is probably the best comparator of data available where we can compare the case fatality rate in inborn errors versus the corresponding general population to see that it's actually remarkably, I guess, similar for PID patient and the general population. There's some really interesting observations that we can draw from this. This is very speculative, but it's quite fascinating that, you know, there was relatively mild disease in people who lacked B cells or lacked antibody due to BTK mutations or agammaglobulinemia, recessive agammaglobulinemia. Likewise, patients who had impaired IL-6 signaling, either due to STAT3 loss of function, STAT1 gain of function, PGM3 deficiency. Likewise, as I said, complement deficiencies or ataxia, telangiectasia, all had mild disease. And in thinking about that, what does that tell you about pathophysiology of severe COVID-19? So I'm just going to walk through these briefly and just give you some speculation, which certainly isn't, I'm not proposing anything that hasn't been said before, but it is interesting to bring it together. So there have been examples of treating severe COVID-19 in the general population with BTK inhibitors, and that's been relatively successful. Perhaps that's reflecting the function of BTK in monocytes, driving a cytokine storm, for example, which actually nicely segues into IL-6 signaling. This is one of many papers which have looked for biomarkers across disease severity for COVID-19, and IL-6 is one cytokine that predicts mortality, as a matter of fact, in severe COVID. So perhaps lack of IL-6 signaling due to these genetic defects may calm that cytokine storm and prevent some aspects of severe tissue damage and immune pathology. And again, complement deficiencies or complement defects, really, again, these are papers which have shown correlations between disease severity and complement activation. So papers published in the last 12 months or so showing increased levels of C5a, for example, in patients who were in ICU or needed mechanical ventilation, and again, correlations between activators of complement and inhibitors of complement function also correlated with severity of disease. So it tells you complement obviously is very important for driving perhaps the immune pathology. Why ataxia patients are mild is totally speculative at the moment. So a lot of that data that I just mentioned has been summarized in these couple of reviews that I was lucky enough to write with, as I said, with Isabelle Meyts and Georgia Berkiol, and they were published in current opinions in clinical immunology and allergy and pediatrics very, very recently. I just want to finish on looking at another approach by which we can understand disease severity. And you'd probably be very familiar with these studies. Many people in the audience are probably involved in them. But these were a number of studies that have been published, again, in the last 12 months, really led by the COVID Human Genetic Effort, which is steered by Jean-Luc Casanova and Helen Su. And this team published in September 2020 reports of inborn errors in type 1 interferon signaling as a cause of life-threatening COVID-19. That was in a couple of % of individuals. But more impressively was this finding that autoantibodies against type 1 interferon was responsible for severe COVID in about 10% of individuals. And those studies have been updated recently. Sorry, there's this figure here, basically showing that if you have inborn errors or phenocopy of impaired interferon gamma signaling or function or production, you can be predisposed to severe COVID. Those studies have been extended very recently with now using a slightly different approach, improved approach, that the incidence of autoantibodies is higher, particularly in elderly people, and these are mostly males. So that can account for up to 20% of COVID deaths. But also mutations in TLR7, which is X-linked, also is pathogenic for severe COVID-19 in about 1% of males under 60 years of age. That was also reported by another group in JAMA last year. And this paper's just come out, which actually links TLR7 deficiency, which reports TLR7 deficiency as well as the ataxia data that I referred to a moment ago. I'm going to stop there, and I'll take some questions if that's all, if there's time, sorry. But that's pretty much where we are now. This work came from the reverse genetics approach, basically, is a phenotype and then working back and finding the genotype, again, highlighting that interferon signaling is very important. And an extension of that, of course, is people who we know have either autoantibodies to type 1 interferon, particularly patients with APOSED or AIR deficiency, or people who have mutations in interferon receptor, STAT1, STAT2, TLR3, and so on, are likely to be susceptible to severe COVID-19. Okay, I'll stop there, and thanks for listening, and I'll join in the discussion and questions.
Okay. All the speakers can turn their cameras on, and they're all together here. So thank you all for this updates and interpretation of the data from the various registries. It's very interesting, and it's very important as we try to understand what this disease does to our patients. We have a couple of questions in the chat. You probably have seen them. Well, I'm going to start with Nizar, since he's been quiet for the longest. And the first question for you is a clinical question, and they're asking, or intern is asking, how do you treat a 12-year-old with DiGeorge syndrome who has COVID stage 4? Is it going to be the same as any other normal children, the therapeutic approach?
Thanks, Fabio. Thanks, intern, for this clinical question. It's kind of difficult to really properly answer a question regarding a clinical case, and there are many things to consider in the discussion and the decision. But as we can see from the different reports that were compiled in different registries and the publications, patients with DiGeorge syndrome don't seem to be the worst, don't seem to have the worst clinical course. So we should probably treat them accordingly to the recommendation for, regarding their clinical stage and of their COVID-19 infection. Look for co-infections also, and probably try to be as aggressive as we can be, just to make sure that we provide the best chances to these patients.
Thank you. And perhaps one question from me about the data you presented. It showed the distribution of diseases that were affected or were reported to be affected in the registry. Does that really match the distribution of diseases in the registries? So all the immunodeficiencies get infected at the same rate, or did you find, looking at the data, some groups of disorders that are more susceptible to infections than others?
Well, yeah, thanks, Fabio. So we actually found that as a proportion of the breakdown of the main PID categories in the COVID-19, as it was also published in the report of Isabelle Meyts and all the international collaborative effort, we found that it's approximately, it's more or less the same distribution as in the largest registries, with 2/3, 60 to 70% of patients with a predominantly antibody deficiency, 20 to 30% of patients with a combined immune deficiency, and actually we had, in the COVID-19, we had less a slightly less proportion of patients with innate immunity, CGD, neutropenia, or other forms of innate immunity. But obviously there are biases in recruiting patients in such a study. But overall, I would say it's pretty much similar to the largest registry data.
Right. Yeah, thank you. And to Adrian, the other clinical question that we got from Intan, would you start corticosteroids in CID patients with COVID category 4 or 5 with low CD4 and poor lymphocyte function?
Again, I think it's difficult to comment on individual clinical cases. I think the evidence from the limited number of cases of individuals with any sort of immune deficiency who we've gathered seems to suggest that dexamethasone and antibody-based treatments in combination are probably the best way forward, particularly if they've got no ability to make their own antibodies. So I think cautiously, yes. If there's the evidence of pneumonitis there, something to treat with the steroids, then yes.
Right. And a question about your data. You show that there was an increased risk factor by age and lymphopenia. Was there anything regarding history of infections? The more infection episodes these patients had in the past, the more susceptible they were to a poor outcome.
Yeah, we didn't gather that data specifically. I suppose a surrogate for that would be the evidence that those individuals who required antibiotic prophylaxis, they would be on antibiotic prophylaxis because they have infections that are not controlled by immunoglobulin replacement, and they do appear to be independently at higher risk. So you're identifying those patients with that variable as a surrogate for all the other comorbidities that they may have. I think that's what the multiple logistic regression, or that would be my interpretation of the model that we've applied to that data. We haven't gone back and looked specifically for how many infections they've suffered in the past year and whether that predisposes to having more severe outcome.
Okay, thank you. Isabelle?
I have actually a question about the SCID patients in the cohorts published. And Nizar, do you have SCID patients in the COVID study?
Yes.
Yes. And do you have also, insight on, because the individual patients have a completely different course depending on if they are post-transplant, even immediately post-transplant, or just prior to transplant, and even if they haven't really had a good immune reconstitution, yet they seem to be doing perfectly well after transplant, whereas prior to transplant they do really bad. So do you have an idea of what's going on there? What are we missing? What don't we understand? Or any ideas about this? I think it's intriguing.
No, right. I think, yeah, so in the COVID-19 survey, we only had 5 SCID patients. We had information on the genotype for 3 of them. One was alpha IL-7, 2 were ADA. I don't have the information on whether or not they were transplanted recently or not, because it was not an exclusion criteria to be transplanted because, as you say, we modify the natural course of the immune deficiency, so it's not a primary immune deficiency anymore, right? But obviously, it's still interesting to collect data on these patients, and as SCID are really the most severe immune deficiencies with no T cell or T cell function and virtually no B cell function. Even if the post HSCT immune reconstitution is suboptimal, it's still way better compared to the pre-HSCT status. So, and again, age is also I mean, they're very young, right? But we tend to think that just boosting a little bit of immunity is certainly enough, but to protect from a severe course of COVID-19. But certainly there is no scientific sound evidence in what I'm saying. It's just really discussing, on the, discussing all together around the table here and not being
I agree. I think we don't know, because there's also SCID patients prior to transplant who are completely asymptomatic, so we really don't know. And so maybe also in this population, measuring the anti-interferon antibodies would be quite interesting to see if that gives us any insight. I don't know. So to be continued. There's another question, I think, for the three speakers together. It's in the chat instead of in the Q&A, but how can we compare the differences between the case fatality rate and the different inborn errors of immunity between the UK registry and the results of the Italian group, and I would say between all the data we have now? Who wants to take this? Any volunteer?
No, right, yeah.
Say,
Nizar, go ahead, because I think I was about to say that the data collection, that some kind of the systematic review of what has been published, and I think we should all contribute to with even unpublished data, right? To try to assess these kind of epidemiological indicator. But it was really I think up to you to answer.
I mean, I can only comment from what's in the literature, obviously not first-hand experience. But one thing we were very conscious of, at least in the paper that myself and Isabelle and Nizar were included in, was making sure that all the patients, and actually the editors were insisting on this too, quite rightly, that all the patients had PCR positive SARS-CoV-2 infection. So when I went through the literature, there's, as you know, there's loads and loads of case reports or cohort studies. I was very careful to make sure we included or excluded patients where there was ambiguity about SARS-CoV-2 PCR data. I'm not saying that's going to explain a whole difference, but I just noted from Adrian's presentation that you commented there might be 10 or 15% or so of patients who were clinically COVID-19, but not definitive. And, maybe I'm splitting hairs and it's not going to make a difference, but that's one thing. But it also may reflect, well, I can't comment clinically. I'll leave that to the clinical experts.
But what I think we could do is really apply epidemiological standard epidemiological analysis with these kind of worldwide systematic review and apply the standardized incidence ratio and also the standardized fatality ratio with the aged and matched according to the worldwide population. So it's called it's really a kind of regular and classic epidemiological way to answer the question.
I think by merging the data together, if there is a way to do that, I think that would be hugely advantageous. With respect to why the UK data generates higher infection fatality ratios, case fatality ratios, I think it's a really very, very difficult question to answer. The most obvious answer is that we have mainly recruited adult patients because the network of UK primary immunodeficiency network mainly represents adult immunologists in the UK. So by recruiting those adult patients, if you look at the median ages in certainly the latest set of data that we've put out there, I think it looks about 10 years older than some of the other cohorts. So I think that might account for some of the difference, maybe not all of it, but it's something that I'm quite eager to understand myself, actually, because I can't explain it, not easily anyway.
Yeah, and also I think, Adrian, that's an important remark. And on the other hand, I think we're also learning. We started in March 2020 knowing nothing at all, and I think we're also becoming better at treating, at diagnosing, and at managing these patients. So I think also probably future cohorts will give us another view and another image of this disease in primary immunodeficiency. So I think the idea of merging all these data is fantastic. One question was how, but I think we'll leave that for another round of discussions. But I think it's a call, this seminar and this grand round, to join forces and to really start and continue registering patients into COPIT or other surveys, because at one point, sooner or later, these data will be merged and will teach us more about COVID-19 and PID. So with that, I would like to thank the speakers and all the attendees for spending their time with us and for giving these data and these excellent presentations. And I would like also to thank Siobhan, who from the Clinical Working Party, who put her effort in organizing this series of webinars and grand rounds. And I think you just have to check your tweets and etc. to find the invitation soon for the next grand round. So thank you very much to all of you who I can see and not, and have a great afternoon or evening. Bye-bye.
Thank you.
Bye, everyone.
Bye.
Thank you. Bye-bye.